Hello, today we will discuss about accelerated idioventricular rhythm. It's from past medicine notes of MRCP Part 1 exam. Accelerated idioventricular rhythm, it's a benign ectopic rhythm which originates from ventricular myocytes. It typically occurs when there is reperfusion after myocardial infarction. It typically has a rate between bradycardia and ventricular tachycardia around about 50 to 110 beats per minute. What is the pathophysiology behind this ectopic rhythm? The most common cause is reperfusion after MI, which leads to increased depolarization rate of ventricular myocytes. There are some electrolyte abnormalities and drug toxicities like cocaine toxicity or digoxin toxicity, which can also lead to increased depolarization rate of ventricular myocytes. Basically, this is an overriding rhythm which occurs when the depolarization rate is faster than the SA node rate. It is precipitated by sinus bradycardia like vagal excess or reduced sympathetic activity. This is precipitated. What are the most common causes? Like I have mentioned earlier, the most common cause is reperfusion following MI. This is the most common cause of accelerated idioventricular rhythm. Then there is a cause which is beta sympathomimetics like adrenaline, noradrenaline drugs. Drug toxicity also causes this rhythm like digoxin toxicity and cocaine toxicity. There are some electrolyte abnormalities, and the other causes are myocarditis, congenital heart disease like VSD, ASD, and cardiomyopathies like dilated cardiomyopathies. We diagnose it on ECG findings. In ECG findings, it basically has a gradual onset and a gradual termination. Why? Because ventricular rate are slightly faster than SA node rate, resulting in ventricular film beats, giving us a wide QRS complexes like greater than 120 milli per second. As you can see here, there are wide QRS complexes, and there is a P wave, but there is no association between P wave and QRS complex. And the rate is, like I have mentioned earlier, between bradycardia and ventricular tachycardia around about 50 to 110 beats per minute. How we treat it? Basically, this is self-limiting condition. We have to just monitor, and it doesn't require any treatment. But occasionally we need atropine to increase the sinus rate, SA node rate to overcome this rhythm. Let's do some practice. A 65-year-old man presents to the emergency department with chest pain and is diagnosed with acute MI. After receiving thrombolytic therapy, his ECG shows a ventricular rhythm with a rate of 70 beats per minute, wide QRS complexes, and no association between P wave and QRS complexes, and he is hemodynamically stable. What is the most likely diagnosis? Look, after MI, 70 beats per minute, no association between P wave and QRS complexes, so the diagnosis is accelerated idioventricular rhythm. Another MCQ. A 50-year-old woman with a history of cocaine use presents with palpitations and dizziness. Her ECG reveals a ventricular rate of 100 beats per minute, wide QRS complexes, and a lack of P wave association with QRS complexes. She is alert and her blood pressure is stable, mean hemodynamically stable. What is the cause of her current condition? Cocaine toxicity, as I have mentioned in the causes of this rhythm. A 70-year-old man with a history of ischemic cardiomyopathy, look, is admitted to the hospital for acute decompensated heart failure. During his hospitalization, his ECG shows ventricular rate of 60, white QRS complexes and no association between P wave and QRS complexes, but he is asymptomatic. What is the initial management? As I have mentioned earlier, that this is idioventricular rhythm and this is self-limiting condition. So we have to observe and supportive care. A 55-year-old man is brought to the emergency with STEMI. He undergoes PCI. Shortly after the procedure, his ECG shows a rate of 90 beats per minute with white QRS complexes and no association, but he is hemodynamically stable. What is the most appropriate step? Continue monitoring without intervention because this is self-limiting condition and we don't need atropine right now because he is hemodynamically stable. A 48-year-old woman with history of myocarditis presents to the clinic for follow-up ventricular rhythm. There is 85 beats per minute rate, white QRS complexes, and no clear association. And physical examination is unremarkable, no signs of symptoms. And what is the most likely ECG finding? This is accelerated idioventricular rhythm, and this is self-limiting condition, and we don't need any treatment right now. So this is all about the accelerated idioventricular rhythm. Hope you have understood it well, and we will also discuss more topics from past medicine for MRCP Part 1 exam. Please follow us on our YouTube channel and support us on Instagram. You will also find other videos like this, and I have made easy for you these MRCP Part 1 exams videos for you. Thank you.